Mr. Chairman, sir, fellow colleagues, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here this morning and sharing my views on a very important subject, very commonly prevalent in India. The main agenda of my presentation is why, where, and when to recommend echo in the patient of metabolic syndrome, which is very, very common, and to evaluate the diagnostic, prognostic, and therapeutic implications, and to compare the benefit versus hazards. This burden is very well known to you. We are listening since yesterday that CVD burden has increased by almost 100% in India in the years to come. See the data, which is showing India is already on the top, much more than anybody else in the world. See the data, the prevalence rate is 14% despite sophistication technology. So whatever intervention is done, but the prevalence rate is rising. The data is shown very clearly that 14% is the prevalence rate and the mortality reduction is not that much as it should be. Shared data has shown that the new emerging risk factors are responsible for metabolic syndrome, which has been discussed at length. Southeast Asia are on the top. To be an Indian, as we all know, is already a risk factor. The disease is premature, diffuse, 10 years early, TVD, very poor peripheral runoff, and on the top of it, there is a faulty lifestyle. As Dr. Manchanda mentioned yesterday, that CAD is a continuum leading to acute coronary syndrome, heart failure, MI, and sudden cardiac death. See the metabolic syndrome, how the various components are responsible for a premature CVD. Insulin resistance is a real challenge for us, how to manage. And it's very clear, all the components have been discussed in length yesterday. See the factors here, erratic consumption. I don't say overconsumption, it is the erratic consumption, malnutrition, responsible for various risk factors leading to involvement of coronary arteries, carotid, peripheral vessels, and ultimately CVD. See the data? The prevalence rate is very, very high in India. See the world data. India is really on the top. The lowest is in Japan as well as some other countries, but more common in India. See the data, world data here. Again, India is going up very high. We have published our own data in Indian Heart Journal. Between the age group of 40 to 60, the prevalence rate of metabolic syndrome is up to a tune of 65%, very high data. And see here, all the components. The most powerful component is the central obesity, 86%. And out of these, 78% of patients had hypertension, very, very common, besides triglyceridemia and low HDL. And see the relationship of triglycerides in the Birmingham Heart Study. And see the data here, the relationship of HDL low and high levels of LDL, how it's responsible for the risk stratification. Inter-heart data, you're aware of. Most of the CV risk factors are modifiable by lifestyle optimization and the early drug intervention. See the data? The CVD risk is increasing day by day. We have to work really hard. Recently published data on 11th of September in Lancet, global maps of level 3 risk factors out of 79 risk factors. Hypertension is on the top in the world. And I think that's the challenge we all have to come across. This is just a daily disability adjusted life people are living in India. 25 years data in last 25 years. See here, metabolic factors. The whole focus is on metabolic factors and behavioral patterns, not only in India, but in the whole world. See the data here. Again, the data is showing it is the metabolic factors responsible, which needs to be tackled very effectively and very meticulously. See the difference in the males and females. The same thing is shown here, that it is the daily data which is very, very important. Data from Mayo Clinic has shown very clearly, people who are metabolic syndrome or obese are 2,660 times more vulnerable to become diabetic. They have heart attacks 360% higher. Higher blood pressure 300 times, premature death 110 times, gallstone 270 times, cancer and degenerative arthritis. HFnF, more volume load in all obese patients. This is just a case presentation which we see very commonly in our emergencies. See here, with the hypertension coming in the OPD, an emergency area, and we see here sustained an injury, EKG revealing a left S1Q3 T3 pattern, and we see here hypoxia, and we see a shadow. And we see here DACO, RB volume overload, increased degree of pulmonary artery pressure. A very classical picture of so-called thrombus lying in the proximal RPA, and we can see a minor degree of enlargement of the main pulmonary artery. And we see here in the next slide, what is the diagnosis? The diagnosis is acute pulmonary embolism. What is the cause? Obesity and sedentary lifestyle. See here, documentation by CT. Another case, very common mode of presentation, accelerated hypertension, BP very high. We do a bedside echo in emergency and we find all the filling pressures are high, whether they are LV filling pressures or RV filling pressures. And LV mass index or LAVI is very high, left atrial volume index. See the data by E prime ratio, and this patient is 18.9. See the data, 3D echo revealing concentric LVH. What is the diagnosis here? Again, ADHF, HFnF, what we call as normal ejection fraction, very common. Underestimated, ill understood, or not understood. And that is the cause of major morbidity in India. The first cause is metabolic syndrome, second cause is metabolic syndrome, third is metabolic syndrome. Others are all component of it. Treat obesity, hypertension will be taken care of. Treat obesity, CVD will be taken care of. See the data here. The most powerful tool to diagnose occult CVD and CAD is by echo. And it is by TDI or by conventional Doppler or by 3D echo or by speckle tracking. This is our own data. And this is just showing how we can see the early diastolic dysfunction. This is our own data. We see here the relationship of E prime ratio, which is very, very important. If it is more than 15, suggesting thereby more LV diastolic pressure. This is the data we published in Indian Heart Journal in 2009. Left ventricular myocardial performance index, very robust, highly robust, to predict early detection of LV diastolic dysfunction up to the tune of 74%. And we have also shown LV diastolic dysfunction is seen in patients of obesity to a tune of 53%. And most of them come with the exertional breathlessness. They don't have angina. It's the diastolic dysfunction. See the inverse relationship. LAVI, 3D module. We see LA volume more than 32 ml per square meter. Huge data to support, which is responsible for high morbidity and mortality. This is our own data suggesting 30% of our patients had an increased LA volume responsible for diastolic dysfunction. This is just to show that LA volume increase and E prime ratio are very, very important predictor of LV diastolic dysfunction. LV mass, first study done in the world. We worked really hard here to produce and show that LV mass increase is very, very important in all the patients of metabolic syndrome. And we can see here 3 types of modules: concentric LV remodeling, eccentric hypertrophy, or a concentric LVH. How do we do it? We measure the relative wall thickness. If only relative wall thickness is increased, it is a concentric left ventricular remodeling, good outcome, reversible. And we see here in 76% of our patients. While concentric LVH, we saw only in limited patients, 11%, which is not reversible, poorly regressible with the medication. Though the claim is enormous, but the data is limited to say the reversibility. E prime ratio, new modalities which are used, but we not have worked on it. And we see here E prime ratio in the LA strain or twist and untwist. This is the data which was shown by Dr. Pancholia yesterday. How we can classify our metabolic syndrome by HSCRP levels. Higher is HRCRP, we say morbid is the metabolic syndrome of more than 9, and we call as grade 4. What should we do? We should act locally and impact globally, and the prevention is the only answer. Optimization of lifestyle is the answer. Control of blood pressure and diabetes is the answer, and a polypill is the answer. Low dose, fixed dose polypill is the answer. We have to find out what strategy we should use besides the tertiary. See the data from WHO or WHF or NICE. Everybody is talking of a heart protection pill because it reduces the memory load, the pill load, and the bill load, and we see a morbidity and mortality benefit as spoken by Salim many times for the last 2 or 3 years. And the data by TIPS is very well known to you. We are producing a lot of metabolic syndrome because of poor lifestyle optimization. See a patient who was on 4 drugs. After a lifestyle optimization and minimum drugs, his requirement of antihypertensives and antidiabetics have become almost 0. You are aware of him, Adnan Sami. What is happening here? On one side, we talk of obesity control, and on the other side, there is a mushrooming of McDonald's. What are we doing? There is total dichotomy in our understanding. See this, what is happening? See here, the guy is suffering from metabolic syndrome, he cannot do exercise, he is making his dog to exercise. See this, what are we producing in the world? And we don't leave our dogs also, who is also becoming obese. We want to change ourselves and we are not changing. I must tell you, ladies and gentlemen, a time has come, it is superior doctors who prevent the disease, It is the mediocres who treat the disease and inferiors treat the full-blown disease, what is happening in the tertiary. A guy, highest experience of treating ADHF in metabolic syndrome. How do we conclude, ladies and gentlemen? Metabolic syndrome, all the three components, hypertension, diabetes, and dyslipidemia, are responsible for a very high morbidity and mortality. If you curtail them, risk stratify them, we are going to win the race of reducing the morbidity and mortality. Echo is a very powerful data. Please subject your patient for echo screening earlier. Lifestyle optimization and effective medicalization, as spoken by Salim repeatedly many times. Low dose, fixed dose, please give it in a big manner. What's the take-home message? Health of millions is at stake with a metabolic syndrome and the occult, hidden terrorist inside us, as CVD. Hypertension, diabetes, and CVD and HFnF. Periodic echo is very important. You control obesity, hypertension will be controlled. You control obesity, sugar, diabetes will be controlled. Obesity and hypertension clinics are need of the hour, and CVD-infected morbidity and mortality can be reduced very significantly. Thank you very much for your patient hearing.